So these are just my affiliations. Uh, I will give you a short evolution and overview on post-prostatectomy incontinence. And the incidence is 3 to 63%, which sounds interesting. Why is that range so far? Because in the old days, we were not able to really define incontinence, and I'm not quite sure if we are now. However, there are papers out there with social continence, with complete dryness, and so on. So that is really a very wide range. But the patients do know when they feel happy or they do not feel happy. Now, the first line treatment anyway is pelvic floor training, no matter if it is a routine care treatment, which is pretty common now already that everyone receives it, or as a treatment for persisting post-prostatectomy incontinence. And there are very nice placebo-controlled studies out there to prove the efficacy of this treatment. Now, it is either just making the patient dry or making him dry earlier. It is clear that we need physical therapy in a way, and I keep telling my patients, if you look at a sportive guy, let's say a swimmer, competitive swimmer, and he switches to cycling, you have to train different muscles to be good again. And here we have a similar situation. We are taking parts away from our continence mechanism, and other parts might have to be trained a little bit. Now, a certain percentage stays wet, unfortunately, and then we have to use the implants. And I guess you know the Scott sphincter that was begun in 1970. It was an early version. And also the Kaufmann prosthesis. Who knows the Kaufmann prosthesis? No one. It was a very nice thing, and he developed something that is now again used in a similar way, but even an adjustable system at that time, which was very forward-looking, so to say. However, I think at that time we were not ready, not from our measurement urodynamically, not from our understanding of post-prostatectomy incontinence, so it didn't really succeed. What we then had is the AMS 800 since 82. It didn't really change a lot, and bulking agents. And it was around 2002 that the Schäfer sling was introduced, something similar to a RAS procedure for men, so to say. And at that time it was in fact the first male sling. There were reasonable results, but as you can see here, continence or success was defined as 2 or less pads. But it was back now nearly 15 years. And the success rate with 72%, 0 pads and 0 pads 42%, and success 72% was less after irradiation therapy. However, there's a big number of patients who were lost for follow-up, so we're not quite sure what was going on with this group. In fact, there's one important thing. 22% of these patients had retightening procedures that we would call now adjustment. So again, the term adjustment comes up here with post-prostatectomy incontinence. We then had the bone-anchored male sling, the Invance, that was introduced 2002 also. The success rate didn't really last long, from 6 to 18 months, from 67 back to 40%. And the success rate was really poor after radiation therapy. In fact, this method is not used anymore. Then we're looking at the ProAct balloons, which were in reality, not looking at the Kaufmann prosthesis, the first adjustable male incontinence therapy, which got the CE mark 2002. And these are two little silicone balloons put at in the position where the prostate used to be, and you will hear more about it later from Erwin Kociancic, who hopefully will show up. And just a quick step to the PROACT balloons. The interesting thing is that they work both with grade 1 incontinence, also up to grade 3 incontinence. So they are not dependent on the grade of incontinence, but on other factors like mainly urethral changes, if there are scars, if there has been something done to the urethra after radical prostatectomy, TURs, whatever, urethrotomies, and you end up with scars, then the PROACT is not so successful, and it is contraindicated in irradiated patients. From then on, more or less, all the new implants that were developed, and I will not go into all of them because this is later on in this session. Is it the Flow Secure, is it the Atoms, the Remix, Zephyr? All these things are adjustable systems, so adjustability may really be a key factor, and we will look at that in the future. So the future aspects are also new hydraulic sphincters, which will be my talk later this afternoon. The Zephyr, the Flow Secure, the Arroyo, and also some magnetic sphincters which are not in clinical use yet. It is also true, and I don't hesitate to say this here at the ICS meeting, that we are lacking good guidelines for decision making. This is why it's important to be here. The guidelines we are looking at mainly work on the degree of incontinence, which definitely is not the only thing we have to look up when we make our indication decision of what to do. We did try from the German working group to come up with some ideas of how to manage male incontinence, and if you want you can look it up, but it is not what you call guidelines, it's just recommendations maybe, but they are based on the latest knowledge of male incontinence. So, as the first choice of treatment, I ask you now to give us your lecture. Thank you.